Welcome back to Mayo Clinic Radio. I'm Dr. Tom Shives.
And I'm Tracy McRae.
Well, the years really go fast, don't they, Tracy? I mean, it's already May, spring in Minnesota, and that also means that it's National Stroke Awareness Month. Each year in the U.S., there are more than 800,000 people who have a stroke. Stroke is a leading cause of death in America and causes more serious long-term disabilities than any other disease.
The older you are, the more likely you are to have a stroke. The risk of having a stroke more than doubles each decade after the age of 55. So we should all be aware of the warning signs of stroke and the importance of getting to the hospital quickly. Joining us in studio is Dr. Robert Brown, neurologist and division chair of stroke and cerebral vascular diseases at Mayo Clinic. Good to see you again, Dr. Brown.
Well, great to be here with you. Thank you.
Thanks, Dr. Brown. You know, we go over this every year with good reason, but explain what a stroke is for our listeners.
Well, there are two main types of stroke, and the most common, which occurs in about 85% of people, is a cerebral infarction or a lack of blood flow to the brain. So in other words, an artery supplying the blood to the brain suddenly becomes blocked, and the brain cells then are starved of the oxygen-carrying blood flow to the brain.
Very similar to a heart attack.
Very
Same
similar.
Thing.
That's
okay?
right.
The artery to the heart gets clogged up, and in this case, the artery to the brain gets clogged up.
That's exactly right.
So that's 85% of the strokes, the majority, and then the other type.
Yeah, the other type of stroke is a bleeding or a hemorrhagic stroke in which an aneurysm or an artery ruptures, leading blood to spill into the brain tissue.
Aneurysm, explain what that is.
Well, an aneurysm is a little saccular or berry-like outpouching off of an artery, and when that little aneurysm ruptures, that can lead to a hemorrhage, a type of hemorrhage called a subarachnoid hemorrhage with bleeding around the lining of the brain.
All right, one other one, TIA. Explain that.
Yeah, TIA stands for transient ischemic attack. Transient means it comes and goes. Ischemic, meaning a lack of blood flow, and attack, sudden onset. So a TIA is a stroke-like symptom that is transient. Now, the important issue, though, is if a person has the sudden onset of symptoms, we'll talk about in a moment, even if that goes away, it's a very important warning sign of a potential future risk of stroke in the days or weeks that follow.
So how does that happen? I mean, why does the TIA happen? I mean, it's like it gets clogged and then gets unclogged?
You stated it exactly correctly. What will happen is an artery will come blocked, but the body has its own system to try to break down clots where they don't belong. So that's exactly what happens is a small clot is present in an artery, but the body breaks it down, the blood starts to flow again, and the symptoms go away.
I love it when you come on the show because it always makes me think of my relatives. And I've said this many times when you've been on the show, but both sides of my family tree, my mom's family and my dad's family, I am thinking right now of all of these people who had spells. I'll use my finger quotes. They would just say, oh, it's just a spell, just had a spell. It was a bad day. And it was only when I started interviewing you that I realized what was happening is that they were actually having many strokes.
Well, and the story you mentioned, Tracy, is unfortunately so common. That is that people will have spells, as they call them, or what are truly TIAs, and they'll ignore them because the symptoms will have resolved. And so they'll think, oh, I'm back to normal. I don't need to worry about this. I don't want to, quote, I don't want to bother my doctor, end quote. But very importantly, that is a key warning sign of a future risk of stroke, so don't ignore those transient symptoms.
On the list of things that kill people, hasn't a stroke dropped a little bit?
It has, and stroke is now the 5th leading cause of death, and we're pleased that with some advances in treatment as well as in treatment of risk factors for stroke, the death caused by stroke is continuing to decline somewhat.
All right, let's talk about the risk factors. List them off.
Yeah.
Well, I mean, aren't they pretty much the same risk factors as for heart disease, heart attack?
That's exactly right. Plaque formation in an artery, the risk factors for that are the same for heart arteries or the brain and neck arteries. And those key risk factors include high blood pressure, cigarette smoking, diabetes, elevated cholesterol. Those are the big 4. And then there are others, including a sedentary lifestyle without much, if any, exercise, obesity, certain sleep disorders, obstructive sleep apnea, and heavy alcohol use, and then certain cardiac conditions, and arrhythmia of the heart, atrial fibrillation, another risk factor for stroke.
So, what about family history? Yeah. Because when I talk about all of these family members that had spells, how important is that for me?
Yeah, great question, Tracy. And there are both genetic conditions that can lead to occurrence of certain types of stroke in a family, but then also some of the risk factors I just mentioned. High blood pressure, elevated cholesterol, diabetes as an example, those can run in a family as well.
I want to zero in on alcohol for just a minute, because there was a recent study published in the Lancet Medical Journal that debunked previous claims that 1 to 2 drinks per day might protect against stroke. Rather, this new article, this new study said that moderate drinkers, I assume that's 1 to 2 drinks per day, increase their risk of stroke by 10 to 15%. Increase their risk of stroke. Yeah. So what's the story?
Well, there's been a great deal of interest over the years in terms of whether alcohol at a very low level could actually lessen the risk of stroke and heart attack. And by low level, meaning less than 1 alcoholic beverage per day for women, less than 2 per day for men, and particularly concentrating on wine. Red wine is a potential protective issue. But it ends up that the data supporting that protective effect is pretty soft, and it's unclear truly if there is any protective effect. But the story that you just mentioned, Tom, is that when it comes to even alcohol use levels just slightly above those low levels I just mentioned, may not only not be protective, but may be harmful in terms of the risk of stroke and heart attack. So I think the key take-home point from that study is we're continuing to learn that alcohol use, even in relatively low levels, probably is not protective, and anything above that 1 alcoholic beverage per day for women and 2 per men may actually be harmful when it comes to heart attack and stroke. So it's all in moderation. All in moderation.
All right, we want to talk about the warning signs. We've talked about the risk factors, and it used to be you would come on the program and you'd talk about FAST. But I recently saw a new list, a new warning sign list. So where are we?
Well, I think the FAST acronym is still the easiest one to remember. Okay. And FAST stands for facial weakness or facial droop, A for arm weakness, S for speech slurring, and T for time. Every minute counts, and if you have the onset of symptoms, seek emergency care immediately.
All right, I like that other list too, though. Sudden trouble speaking, sudden trouble seeing, sudden trouble walking, sudden one-sided weakness, and sudden severe headache. So, and these came from the Stroke Association too, didn't they? Probably both of them.
Exactly. The FAST is the acronym, just a way of remembering it. And the symptoms and signs that you just mentioned, Tom, are a little bit more of a comprehensive list. The bottom line is the sudden onset of difficulty doing something. Walking, inability to see, weakness on one side of the body, numbness on one side of the body, difficulty understanding others, sudden, unexpected headache, unlike anything you've ever had before. All of these are risk factors, or all of these are signs and symptoms of stroke.
Yeah, the word sudden then being the key piece in there. And then also the sudden clearing of these types of symptoms would just be just as important.
It is. In that situation, it is that TIA we talked about a few minutes ago. And if the symptoms don't resolve, then that means that there's a stroke evolving and you should seek emergency medical care because we might be able to do something about it.
All right, and we're going to talk about that coming up. Time for a short break. May is National Stroke Awareness Month. Our guest is an expert on stroke, Dr. Robert Brown. Time for a short break, but when we come back, we'll talk about how they diagnose a stroke. And as Dr. Brown just mentioned, we'll talk about treating a stroke and how important it is to get to the hospital quickly if you think you're having one. Welcome back to Mayo Clinic Radio. I'm Dr. Tom Shives.
And I'm Tracy McRae.
We are with neurologist and stroke expert, Dr. Robert Brown. We've talked about the symptoms of a stroke. We've talked about the risk factors, and now we want to talk about the diagnosis and treatment. And first of all, if someone comes to the hospital quickly when they have sudden onset of something, how do you determine whether or not it in fact is a stroke?
Well, the history and talking to the patient or their family members or some other observer, as well as the neurologic exam, taking a look and seeing if there's some weakness or some challenges that the patient is having, those are the the key issues to start with. But then that will be immediately followed with a CAT scan. A CAT scan is a picture of the brain that we can obtain very quickly, and that can help to tell us if there's any bleeding into the brain tissue, that hemorrhagic or bleeding type of stroke. And if that's not present, that can help to tell us that there might be an ischemic stroke, or that lack of blood supply type of stroke present.
So if you think you're having a stroke, if you think you're having a heart attack, you chew an aspirin or two. If you think you're having a stroke because it could potentially be a bleeding stroke and not the kind where an artery is blocked, do you chew an aspirin or no?
That's a great question, and that means in a small percentage of the time, if you take an aspirin, you may actually be worsening the stroke. Now, that said, information from our medical literature suggests that it's probably fine to go ahead, and if you're having stroke-like symptoms, taking the aspirin in that way, because the likelihood you're going to worsen any bleeding stroke, if present, would be very low.
The difference between a heart attack symptoms that a man has and a woman has are different. Yeah. Is there a difference for men and women when it comes to stroke?
Yeah, there are some differences as well. We've looked at that both here in our research and elsewhere, and it does suggest that women may be less likely to have some of the very focal symptoms, such as weakness on one side of the body, as an example, and may have more generalized symptoms that can be a little bit more harder to diagnose immediately. But in general, the symptoms that we talked about earlier are pretty consistent between men and women.
What about younger folks versus older folks having strokes?
Yeah. Well, it brings home the point that stroke can occur at any age, even though it's of higher occurrence as we get older. But the symptoms that occur typically are relatively similar, young versus old, in terms of the symptoms we talked about a few minutes ago.
And do young people have spells like older people do?
They can.
Okay.
TIAs can occur prior to stroke at literally any age, including children and above. They can have TIAs. Some, and important to emphasize, not all strokes are preceded by that warning symptom.
Sure.
All right, we've made the diagnosis. What happens next?
Well, it is an exciting time when it comes to stroke treatment. And I remember back, I think I first had the opportunity to visit with you both about 25 years ago.
It's probably true.
Yeah, and so I was looking back, and at that point in time, we were still in the infancy in terms of acute stroke treatment. But things really changed in about 20 years ago when clot busters started to be used for strokes. And by clot busters, I mean something given into the vein that would lead to the clot in the artery to dissolve, and so we'd start the blood flow up to the brain. Now, fast forward to a few years ago, we began to develop techniques using small plastic catheters, so little plastic tubes that could be inserted from a groin artery and then advanced all the way up into the brain artery. And from the tip of that catheter, we could extract the clot that was blocking the artery. And our neuroradiologists, neurosurgeons are adept at doing that. So imagine this little plastic tube in the artery extracting the clot, and blood is flowing to the brain.
Incredible. Now, the important question is, how soon after the clot forms do you have to do this to protect the brain, to prevent damage to the brain?
Yeah, great question as well. And when it comes to the clot busters, in general, we use those in up to 3 hours after onset of symptoms, and in some people, up to 4.5 hours after onset. For the catheter-based therapies, we can extend the treatment window out. Now, prior to a couple years ago, we could extend that window out to about a 6 to 8 hour period of time. But here again, things have changed markedly. We found out that by utilizing fancier pictures of the brain called CAT scan perfusion or CT perfusion studies, we could clarify immediately what part of the brain had already died off, was already infarcted, and what part of the brain was just lacking in blood flow, but still salvageable, still a part of the brain that we could save with resurrection of the blood flow to that area of the brain. So in other words, patient comes in, we obtain these fancier types of images now, and we're now able to extend the treatment window up to even 16 to 24 hours in selected patients in which the area of infarction or complete loss of cells, death of the brain cells, is small and the area of salvageable tissue is large. So now we're treating in some people up to 16 to 24 hours.
Pretty incredible. But what happens if you're not close enough to a center where they can do this?
Yeah. Well, many areas of the country and outside of our country as well have what are called telestroke networks, in which one can present to one's local hospital and via an audio and video connection to a major medical center, be able to connect with a neurologist, review the patient's situation, even see the CAT scan, and make a decision whether we should go ahead, start the clot buster therapy there, and then have that patient transport via helicopter to a medical center where those catheter-based therapies may be available.
So everybody's got the clot buster.
Yep, most even very small hospitals across rural areas do have a CAT scan available. That's a key to be able to get the picture, and then have clot buster therapies as well.
For sure, that must be why it is now 5th instead of 4th in risk for death.
That is part of it contributing to that.
So what are we going to do to get it to 6th or 7th? What's on the horizon?
Well, great question. We're continuing to identify which of the patients may benefit from those more advanced therapies even after that early time frame. In other words, extending the time window for treatment is a major advance forward. And interestingly, now there's some information that suggests we may be able to use clot busters even beyond the 4.5-hour period by using a little bit fancier imaging, the CAT scan or MRI scan that I alluded to a few minutes ago.
All right, so now we know what you do for a stroke where it's caused by a clot.
Yeah.
But what about the one that's caused by hemorrhaging blood vessel?
Yeah. Well, the bleeding types of stroke, the hemorrhage type of stroke, those continue to be a significant challenges. And there are some of those patients that can be treated surgically by actually extracting the clot. A neurosurgeon goes in, excises the clot. But that's a selected group of people, and others of those with hemorrhagic types of stroke, we really rely on optimal nursing and physical therapy type of care. But I should mention that's an area of neurology here again that we're working on extensively to try to clarify which of those hemorrhagic strokes may benefit from even new and different types of surgical approaches.
But are you even likely to survive a hemorrhagic stroke?
Yeah. Well, oftentimes a hemorrhagic stroke will survive long enough to get to the hospital, be able to get the CAT scan done, and be able to have some urgent care. And I should say there's a tremendous amount of research being done to try to determine if there are new innovative types of surgical procedures that may be able to treat those bleeding types of stroke.
So they actually take the blood out of the brain to take the pressure off.
Exactly right. And I should mention too, aneurysm rupture types of strokes, there are tremendous advances there. The survival following aneurysm rupture now is much better than it was even 20 years ago.
You are doing so well.
Well, it's a testament to all of my colleagues nationwide and worldwide that are working so hard on this topic.
Well, May is National Stroke Awareness Month. Stroke, a leading cause of death and disability in this country. And remember the FAST. Say it once more.
Yeah, FAST. So facial droop, arm weakness, speech slurring, and T is for time. Seek emergency care immediately if you have these symptoms.
Our thanks to Dr. Robert Brown, neurologist and division chair of stroke and cerebrovascular diseases at Mayo Clinic. Dr. Brown, thanks so much for being with us.
Well, thank you so much for having me back again. I appreciate it.